Hi everybody, this is Chris Morosky, and this is a short video on maternal physiology. I'd like to thank Dr. Adam Borgita for his contributions to this video. The goals and objectives of this video are to discuss the various changes that must occur to the maternal organs in order to support a developing fetus. In terms of the maternal physiology, dramatic changes occur to accommodate the fetus. These physiologic changes affect every organ system, and they must convert the mother into an incubator by altering her physiology and immunology. The goal overall is to nourish the growing fetus and prevent rejection. By producing numerous hormones, the placenta alters maternal physiology. All the changes increase blood flow and transfer of needed nutrients to the uterus and the fetus, and every organ system is affected either directly or indirectly. The first evidence of pregnancy is a missed period. Women also complain of urinary frequency, breast tenderness, and nausea and vomiting. In terms of body water metabolism, there is a total 6 to 8 liter increase in total body water from the beginning to the end of the pregnancy. The fetus, placenta, and amniotic fluid account for 3.5 liters of that increase. The rest is extravascular and in the uterus, breasts, and adipose tissue. Pregnancy is a volume overloaded state. There is a new osmoregulation set point to retain sodium and fluid. This results in hemodilution, a physiologic anemia of pregnancy, and increased cardiac output. As you can see in this chart, from the missed periods and last menstrual period all the way through 4, 8, 12, and 16 weeks of gestation, the plasma sodium concentration and the overall plasma osmolality decreases greatly up through, in this chart, to the second trimester. Also, similarly, there is an increase in the cardiac output. This is driven by both the components of cardiac output, and you can see that compared to the pre-pregnancy state, there is a gradual increase in heart rate. There is also a gradual increase in stroke volume, and when put together, this shows a gradual increase in the cardiac output throughout pregnancy. And in the postpartum state, you can see the cardiac output returning to normal almost immediately postpartum. Where is the cardiac output going? You can see that the majority of the increase actually is to the uterus. In the non-pregnant state, the uterus receives about 2% of the cardiac output, whereas in the pregnant state, it receives 17%. The breast also increases its blood supply. You can see that the renal blood supply and the skin is pretty much the same, non-pregnant compared to pregnant. Position is very important of the mom in terms of her cardiac output. When the mom is lying left lateral and right lateral, there is little difference in her cardiac output. But when she is lying supine, flat in her back, this greatly decreases. When she sits up, this is pretty much the same as lying on a right or left side. And when she stands, this greatly falls due to pooling of the blood in the lower extremities. These are all lower compared to the control patient who is not pregnant. Looking at the cardiovascular system, blood pressure drops in the mid-pregnancy and rises again in the third trimester. And this is due to the progesterone effect on smooth muscle. There is overall a drop in systemic vascular resistance. This chart shows exactly the decrease in systemic vascular resistance, which is fairly steady in both diastolic and systolic values down to 24 weeks and begins to rise again slightly at term, and you can see that it returns pretty much to normal 12, 24, and 52 weeks postpartum. Looking at the specific hemodynamic properties, overall there is a 43% increase in cardiac output. There's a 17% increase in heart rate. There is a drop of 21% of systemic vascular resistance and 34% for peripheral vascular resistance. And oncotic pressure also goes down 14%. There is minimal change in mean arterial pressure, pulmonary capillary wedge pressure, and central venous pressure. Also, it's important to note that there is approximately 300 to 500 cc's of blood within the uterus at term, and when the uterus contracts, there is an autotransfusion to the maternal cardiovascular system. Looking at her before labor state and then watching as her cardiac output changes in labor with stronger and stronger contractions, you can see that as she progresses through labor, each contraction returns more blood into the vascular system, increasing her cardiac output. And then looking 1 and 24 hours after delivery, again, this returns to her pre-labor state. There are also marked changes in the respiratory system. Pregnant women have a hyperventilation with an increase in minute ventilation due to an increased tidal volume. Again, minute ventilation is tidal volume times respiratory rate. The total lung capacity decreases by approximately 5% as the growing fetus begins to push on the thoracic cavity. The functional reserve capacity decreases, and this is driven by both a decrease in the expiratory reserve volume and residual volume. There is an increase in the inspiratory capacity by 5 to 10%, and the vital capacity is unchanged. Looking here in the graph of the respiratory system, looking on the left, you can see that there is no change in the non-pregnant and late pregnancy state of vital capacity. What you do note within this is that there is an increase in tidal volume, and this decreases the expiratory reserve volumes. Adding this up, there is an increase in inspiratory capacity, and there is a decrease in the functional residual capacity, which is driven largely by the decrease in residual volume. Hematologic changes, note that the blood volume increases by 40 to 50% in pregnancy. The first plasma expansion starts at approximately 6 weeks gestational age. The red blood cell mass does rise, but it rises at a slower rate than the plasma volume, and this results in a physiologic anemia of pregnancy. This is ultimately designed to protect the mother from hemorrhage and ensure uteroplacental perfusion. Looking at the graph, you can see that there is a steady rise in the plasma volume by the dotted line at the top. This adds up to a steady increase in the blood volume, as you can see in the bold line. And while there is a rise in the red blood cell mass, this is less than the plasma volume, again leading to the physiologic anemia of pregnancy. Other hematologic changes include the platelets showing a slow progressive decline of approximately 8%. This does put the patient at risk for gestational thrombocytopenia. The white blood cell count does rise every trimester, and this is mostly increased polymorphonucleocytes. There is a decrease in cellular immunity, and there is an enhanced antibody immunity in pregnancy. Coags change also predisposing to hypercoagulability. The hypercoagulable state of pregnancy is caused by an increase in venous stasis in the legs, an increase in liver production of coagulation factors driven by the estrogen production from the placenta. There is an increase in fibrinogen levels and decreased fibrinolytic activity with lower protein S and C levels. The changes to the urinary system include anatomic changes. The kidneys enlarge by 1 centimeter. There is right greater than left mild pyelectasis, which is normal in pregnancy, and this is due to mechanical compression by the pregnant uterus, as well as hormonal changes from the progesterone of pregnancy. This all resolves by 6 weeks postpartum, but it does increase the pregnant woman's risk for urinary tract infections and kidney stones. The renal hemodynamics show that there is an effective renal plasma flow increase by about 75%. Glomerular filtration rate increases by 6 weeks and up to 50% by the end of the first trimester. This can be measured with the creatinine clearance, which increases 150 to 200 milliliters per minute. Clinically, you may see a diluted BUN, creatinine, and uric acid, and it's also possible to see a good amount of glucoseuria due to excess excretion of glucose in pregnancy. Here this graph shows the steady increase of insulin clearance, creatinine clearance on infusion, and creatinine clearance at 24 hours as you go through the middle of the pregnancy. And looking towards the very end of the pregnancy, there is a slight decrease in these values. The changes in the alimentary tract are driven by placental hormones. Many women experience nausea from 6 to 8 weeks in pregnancy. This is thought to be related to the rise in placental HCG levels. GERD is common from relaxation of the gastroesophageal junction and mechanical compression. Constipation is present in 11 to 38% of women. The enlarged uterus can displace the appendix. Gallstones are much more common, and serum albumin and total protein levels show hemodilution. As far as the skeleton is concerned, there is a pseudo-hypoparathyroid state of pregnancy to provide calcium to the fetus. Generally, there is no pathologic loss of calcium from the maternal bones. There is active transport of calcium across the placenta, and the fetus accumulates 21 grams of calcium throughout the pregnancy, with 80% of this being in the third trimester. The calcium needs are met through increased intestinal absorption. The skeleton itself shows increased lordosis. This helps keep the center of gravity stable while the uterus is anterior. There is increased complaints of low back pain. The ligaments relax from a hormone called relaxin. The symphysis widens, and this can sometimes be painful. This graph shows calcium regulation, with total calcium decreasing by the second trimester, while ionized calcium remains the same. Parathyroid hormone really drops off in the first trimester and slightly begins to rise again in the late second and early third trimester. Vitamin D levels rise in the first trimester and remain elevated throughout the pregnancy, and the same is true for calcitonin. Endocrine changes show that the thyroid function tests are very altered. Overall, the patient does remain euthyroid and has a normal TSH level. There are increased thyroid binding globulin levels, leading to an increased total T4. This also causes a decreased T3 reuptake. The free thyroxine index is normal, and free T4 is also normal. The only difference is in the first trimester when HCG can mimic the activity of TSH. This graph nicely shows what happens in the first trimester with the rising HCG. Overall, there is a drop in TSH in the first trimester, and you can see a bump in free T4 in the first trimester as well. From there on out, these levels resolve and slowly decline just slightly throughout the pregnancy, but overall are normal. As you can also see, the thyroid binding globulin increases by the second trimester, and this raises the total T4 as well. Other endocrine changes include an increase in adrenal function. There is more acne and increased hirsutism, which is common from increased androgens. The pituitary enlarges, and prolactin is 10 times higher in pregnancy, while FSH and LH are suppressed from the estrogen and progesterone feedback from the placenta. As far as the pancreas and fuel metabolism is concerned, there is an insulin resistance from human placental lactogen, which is one of the major hormones made by the placenta. This causes a fasting hypoglycemia, a postprandial hyperglycemia, and a hyperinsulinemia commonly seen in pregnancy. The increased demand results in beta cell hypertrophy in the pancreas, and human placental lactogen can be very diabetogenic. Gestational diabetes can be the result. In this graph, the normal pregnant woman in the black dots is compared to the non-pregnant woman in the open squares, and it can be seen that there is large increases of insulin following meals in the pregnant state. Similarly, glucose also rises in the normally pregnant woman much higher and drops even lower just prior to meals in the pregnant patient when compared to the non-pregnant patient. And often we say that there are higher highs and lower lows in terms of glucose in pregnancy. In terms of other components of metabolism, amino acids are actively transported across the placenta, and they can be used as an energy source and for protein synthesis, and total fats and lipids are also increased in pregnancy. This graph shows the increase in triglycerides as well as an increase in cholesterol, which is seen steadily from the first trimester all the way towards the end of pregnancy and on towards lactation. There are several skin changes in pregnancy. There is an increase in hyperpigmentation. One of these is chloasma, which is darkening of the skin of the face. The linea nigra also darkens. It is not uncommon for new nevi to develop, but melanoma itself is not more common in pregnancy. Changes in the hair are common. There is a mild hirsutism, as was mentioned before, due to the increased androgens. Also, there is an increased hair in the anagen phase of hair growth during pregnancy. After pregnancy, this can lead to a condition called telogen effluvium, where there's a great loss of hair after delivery. This generally resolves over 6 to 12 months following delivery of the baby. Other common changes are stria distensae. These are stretch marks which occur in 90% of women. This is due to the rapid distension of the skin from stretching from the gravid uterus. There is also increased estrogen and steroids which promote tearing of collagen. These are usually permanent, but they do fade with time. There are also vascular changes in pregnancy that can be seen in the skin. The high estrogen levels lead to a proliferation of blood vessels. Women are also unstable to flushing. Spider angiomas are common. Palmar erythema is also seen, and most of this fades away within 3 months postpartum. So that's about it, everybody. As you can see, we did cover the various changes that must occur to the maternal organs in order to support a developing fetus. I hope you found this educational and helpful, and good luck with everything. We'll see you soon in class.